This conference will now be recorded.
As hemorrhagic shock patient, based on the age, young age, well-built patient, he can overcome it well if you manage early. But if you are not able to manage it early, how you will know that patient is in shock? Patient is in shock. How you will know? Some clinical signs and features are present in this, like heart rate, it will increase, blood pressure, it will decrease, and CNS, like patient is consciousness and patient is having anxiety and all, and urine output. And with BP, you can also measure pulse pressure and respiratory rate. It will also increase. Can anyone say what is about SIRS? What is the full form of SIRS? SIRS. Have you heard the term? SIRS, Kicksofa, septic shock, sepsis. These all are important topics. Did you heard about SIRS? What is the full form of SIRS? Systemic inflammatory response syndrome. Okay. Systemic inflammatory response syndrome is junction between the patient normal healthy or post-operative patient to shock. It is an intermediate state. When you are going to that, the patient is in SIRS. SIRS means systemic inflammatory response syndrome. Means body's response towards the loss of blood, or it is called systemic inflammatory response syndrome. There are four components in systemic inflammatory response syndrome. Heart rate, respiratory rate, temperature, and WBC. Heart rate is more than 90, respiratory rate more than 22, or PCO2 more than 32, temperature less than 36. Can anyone say? Do you know about this? More than 38. WBC count less than 4,000 or more than 16,000. 16K. These are four components of SIRS. If you have more, two or more than two, then you can diagnose it as SIRS. SIRS with documented infection is called sepsis. Sepsis with underperfusion of tissue is called septic shock. Okay, this is like link. Now nowadays some definitions are changed. Like quick SOFA with documented infection is called sepsis. It is changing nowadays. But SIRS is also important topic for your examination point of view. So I am discussing SIRS also. Okay, then this one. Hmm. Now you are clear about SIRS. Can anyone message? Okay. Heart rate is going to increase in hemorrhagic shock. Blood pressure will decrease. CNS anxiety or something like that will be present. Urine output will decrease because of decrease in pressure. Pulse pressure will decrease, and respiratory rate will increase. And it will be different components start in different classes. Okay, like in class 1 there will be only increase in heart rate. In class 1 only heart rate will increase. In class 2 heart rate will change, increase, but BP will not decrease, but pulse pressure will decrease, respiratory rate will increase, urine output mild decrease will be there. Urine output will mild decrease will be there. And CNS mild anxious will be started. So this is the most transition phase between normal patient, and if patient is in class 2, you will definitely come to know that is it is in patient is going to shock. And in class 3, along with above things, BP will also decrease, and anxious patient is a little bit confused also, and urine output will decrease to 5 to 15 ml per hour. And okay, then class 4, everything will be changed and patient may be confused or lethargic. Urine output may be nil. BP decrease, heart rate more than 140, and these are the different changes of entity in different classes. So that's why this classification is important. Even this classification questions will come in your super specialty exam also. This is basic thing. You have to know definitely what about this classification. Okay. Now we are going to discuss about hemorrhagic shock in detail. Hemorrhagic shock, as I already said, this is present in post-operative patient or traumatic patient. In post-operative patient, maybe you will come to know it is due to intraoperative blood loss or ongoing blood loss. And if it's ongoing blood loss, you have to diagnose where it is bleeding by doing any investigation like ultrasonography or CT. And if it is a traumatic blood loss, whether it is internal bleeding or external bleeding. External bleeding you have to decrease by compression. As I already said in trauma class, CABC. Uh, Anyone remember CABC full form? ABC, do you remember ABC? Airway, breathing, circulation. Okay. And CABC will come into role in traumatic patient. C is nothing but compression. If it is there any ongoing blood loss, you have to decrease C because it will decrease the patient's condition from shock. If you decrease ongoing blood loss and if you give the IV fluids, patient will recover well. So we have to identify the hemorrhage first, and immediate resuscitation whenever is to be done, and hemorrhage control to be done if it is ongoing blood loss is there, like damage control surgery. Damage control surgery completed for you. Damage control surgery contains two components, like if there any bleeding, control of bleeding. If there is any contamination, like in perforation, feces will present in abdomen, it will release to the abdomen. So some peritonitis will be there. So decrease in contamination, decrease in bleeding, and decrease in contamination is the two most important components of damage control surgery. Okay. In hemorrhagic shock, patient usually present with in post-operative time. Patient will present with hesitation, like and cold calming extremities because of decrease in BP. Peripherals will become cold, and tachycardia, as I already said, and hypotension, pallor, uh, weak or absent peripheral pulses, prolonged capillary refill time. Systemic examination will be is a confirmatory thing for shock. Investigations, clinical entity to identify the shock, hemorrhagic shock. Hematological and biochemical investigations to be can be done, like complete blood picture to be done, and lactate levels, blood grouping to be done for cross matching for any blood transfusion thing and all. Radiological investigations like E-FAST, if it is in trauma, E-FAST is nothing but extended FAST. Extended FAST is focused assessment and sonography of trauma. Okay. Some three or four important things, like definitely primary things to be done, to be seen in shock are heart rate, BP, urine output, and respiratory rate. These things you have to definitely see. These are your clinical findings. Okay. And how will you manage? While diagnosing only, you have to start the treatment, like put two wide bore IV cannulas and transfuse 1000 ml, like two 500 ml bottles immediately to decrease shock. If it is, you can diagnose, you can classify these patients into responders, non-responders, and partial responders. Responders is like patient is improving his symptoms by giving these IV fluids. Only IV fluids, patient will recover. Like, do you know these names? Responders, partial responders, and non-responders. Responders are those who recover well with IV fluids because patient had previous blood loss, but there is no ongoing blood loss. Patient is recovered well. And partial responders, like patient is recovering by giving fluid, but immediately after 10 to 15 minutes his BP is again in fall and heart rate is increasing because there is ongoing blood loss. Ongoing blood loss, like internal bleeding, you are not able to see that ongoing blood loss. That is internal bleeding is there. So do you understand? And non-responders, even though you are giving 1000 ml fluid, patient is not going to improve his symptoms because that ongoing blood loss is more than your transfusion fluids. Okay. If there is ongoing blood loss, some not only crystalloids, we will divide these fluids into crystalloids and colloids. Crystalloids is nothing but IV fluids. Colloids is albumin, hetastarch, hexastarch, and blood components. These are colloids. We will prefer first crystalloids. If patient is having class 3 or class 4, then you can give that colloids also. And blood transfusion can be preferred if there is ongoing blood loss and hemoglobin is less than 8 and platelet is less than 50,000. As I already said, there is a monitoring should be done this in hemorrhagic patients like pulse rate, respiratory rate, BP, and urine output. And some invasive, these are non-invasive things to monitor. And invasive things to monitor are pulse oximeter, uh, CVP can be monitored, and base deficit and lactate can be monitored. And you can divide this management of this topic. Initial resuscitation, initial resuscitation, control of hemorrhage, as it is component of control of hemorrhage, and early stabilization or definitive management. Definite, definitive or early stabilization. Okay. As I already said, you have to start immediate crystalloids or IV fluids 1000 ml. That comes under initial resuscitation and monitoring. Monitoring should be started. And control of hemorrhage is a component of damage control surgery. If patient is having some components like metabolic acidosis, hypothermia, and in those patients you can't take risk taking patient to the surgery for more than 2 hours. Like you have to complete surgery within half an hour. That is nothing but control of hemorrhage and control of contamination. And then later you can go for definitive surgery like anastomosis. If pathological if fractures are there, you can treat those. Okay. So this is hemorrhagic shock, and there are other shocks also. Uh, Other shocks also elaborated in your class or not? If not, I will take from next class onwards. Can anyone reply? Do you understand this hemorrhagic shock or not? Is anyone there in the class? Okay. One reply, two reply, three. Do you understand this hemorrhagic shock? This was not completed for your previously, na? Completed. Someone messaged yes, sir. Yes, sir. For what? Understanding the class? Not completed. Okay. So, what about other shocks elaboration? Cardiogenic shock, septic shock, endocrine shock, neurogenic shock. What about these? Septic shock completed in pathology. Okay, in surgery not completed. Na surgery shock is different and pathological shock is different. Okay. And someone said classification of shock in like cardiogenic, hypovolemic. Those are not. Those are also one of the classification. And another classification is distributive shock, obstructive shock, neurogenic shock, and septic shock. Septic shock comes under the septic shock and neurogenic shock comes under distributive shock. This classification is different. You have to know that classification also. Okay, I will complete this class from now. So shock was not completed for you in surgery. It is completed in pathology. No? In surgery also it is completed. Someone said completed in during starting of class. That's why I haven't taken class. I'm not pathology assistant. I'm surgery assistant. Surgery is different now. Can anyone message in surgery shock is completed or not? Can anyone say whether you have completed your? Someone said shock completed in pathology, not in surgery. On last reply, I will complete class and go. Can anyone say it? Not completed. That's what I am asking. During class starting only you should have said no. Okay. Today one topic is completed. Next class I will do introduction of shock and I will complete other. I will try to complete other topics like cardiogenic shock, distributive shock, and rest. For today, I am completing class. Thank you. Thank you for your patience.